Good evening, everybody, and welcome to Beyond the Otoscope. This evening, we are going to discuss the aging otolaryngologist, and aging begins very early in life. I'm Bob Sadeloff, and our distinguished panel includes Roger Crumley, Professor Emeritus from the University of California at Irvine, former president of the Triological Society, chair at UC Irvine for 20 years, and a wonderful musician. Stacy Gray is the Walter Augustus LeConte Associate Professor at Harvard Medical School. She's the Vice Chair of Education and Residency Program Director at Mass Eye and Ear. Earl Harley is Professor of Otolaryngology and Pediatrics at Georgetown. He had a distinguished long career in the U.S. Navy, served as Vice Chair at the Regional Naval Medical Center in San Diego, and interim chair for a few years at Georgetown. And Jonas Johnson, who needs no introduction, is Emeritus Distinguished Professor at the University of Pittsburgh. He was chair at Pittsburgh for 16 years, president of the Triologic, and of course, president of the American Academy of Otolaryngology, Head and Neck Surgery. So welcome, and thanks to all of you for joining us. None of the panelists has a conflict of interest relevant to tonight's presentation. Tonight's presentation, however, is relevant to all of us in medicine. The age of the population is growing. There are about 500,000 people 65 and older in 2006, and in another 5 years, that'll reach 1 billion. In the U.S., by 2030, 20% of people will be 65 and older, and we're having a lot more people over 100 years of age. It's doubled every decade. Life expectancy for people born now in the U.S. is 78 years for males, 81 years for females. 1 in 20 males born now will live past 100, and 1 in 10 females will live past 100. Those aging statistics include those of us who practice medicine. So to start our discussion, Stacy, your partner and faculty member, Ernst Weber, is going strong. That's Ernst Weber of tuning fork Weber test fame. He just celebrated his 300th birthday, and you're starting to get a little concerned about whether he should still be teaching your residents for whom you're program director, and whether he's the person to whom you would send a family member. What do you do about it? How do you approach him?
I like how you're asking me this question, Dr. Sadeloff. You're making me start off this discussion. This is very tricky, and I think something that that we all really could learn sort of how to try to approach this. I think the first thing is just obviously communication, and certainly hopefully if you have a physician that there are some concerns related to this, the first thing would just be having a discussion. And who has that discussion? Probably the chair of the department. A lot of times people who have colleagues or friends, obviously, really to understand what sort of his idea is about his current practice and expectations going forward. I think a lot of institutions are considering sort of some kind of actual formalized testing for physicians after a certain age. We don't have a system like that currently in our system. I'll be sort of interested to hear if other people on the panel actually have systems in place for that. But I think the first thing is just really having an honest conversation with the physician.
We will be discussing testing and other assessment options, but it's interesting that your first thought was to talk with him. Uh, Ask him how he is. Ask him how he's doing. Uh, Earl, do you
Yes,
believe
that's
the
fine.
answers?
Stacy's answers? Is that what you mean?
No, no. You've asked your 300-year-old partner how he's doing. Uh, is his answer credible?
No, it's not. Thanks, Bob, for the question. No, it's not, because at age 300, he's still practicing. I think that represents a lack of insight, introspection, uh, losing track of his own ability, or thinking he's more able than he really is. So I think whatever answer he gives is not, cannot be depended on. You would need an outside observer, somebody who's seen him in the operating room or seen him with patients. But yeah, no, it represents, and that's a problem with aging. It represents people who don't know when to slow down, when to back off, and and see the decrease in their own abilities.
Well, as it turns out, I would agree with your answer, but there are relatively few things in aging on which there are good data, and this happens to be one of them. There's no relationship between an older physician's self-assessment and objective assessment of cognitive function. So you're right, you can't believe him, but it's not just common sense. The the studies show that self-assessment, while communication is important for a lot of reasons, uh, gathering credible information to make decisions is not one of them. And it's an important issue. And in the last available survey in 2022, out of 155,000 active surgeons, 25% of active surgeons are over age 65. So that's a big deal. And they too have been studied. And in general, they report no perceived cognitive changes. And we all know from other data that that's not likely to be true. So, Roger, what kind of performance do you expect from older surgeons?
Well, there are two questions that I was thinking about here. First of all, is what do you do about the physician who's seeing patients, and then what do you do about the physician who's still doing surgery? And those two are different, in my view. So in terms of surgery, I like what Stacy has mentioned, is that there needs to be somehow an objective assessment of surgical skills and responses to dynamics in the OR by by maybe a committee, a departmental committee of two or three or four, including the chair, and then a discussion, as mentioned, a discussion with the surgeon, even though that may not equate to the objective findings of the committee.
Jonas, what would you like to add? What do you expect to see
So,
as surgeons age?
uh, oh, I was going to answer the last question.
Okay.
I think that we all understand that aging is normal. And the normal part of aging is you begin to have difficulty both in the physical realm and the mental realm. Now, the problem, I think, uh, is that it's very difficult to standardize because people are so different. And when I was involved with patient safety for our own organization, um, we found disabled surgeons, but it had nothing to do with age. So this is a challenge. At the same time, our structure has always been that surgeons receive performance evaluations at regular intervals. And your evaluation reflects the people that observe you in your environment. In other words, your other partners and other physicians. And it includes your outcomes. So if a surgeon is having outcomes that are not expected, that is having complications and poor outcomes, that is a red light that should call attention to the potential need for some intervention.
That, of course, is true, and we all recognize it. Um, as the evening goes on, we will be thinking about things that I hope will allow us to recognize potential difficulties before we have bad patient results. I would suggest that while what you said is correct, unfortunately still true, that part of our job in contemplating the aging surgeon and the aging otolaryngologic surgeon and clinical otolaryngologist is to find ways to recognize and address issues before our partner has 6 lawsuits in 6 months. That's that's not good enough, as you know. And for those of you who are joining us this evening, I think that the other department chairs and former department chairs on the panel will agree with me that this is one of the hardest issues, and it's unfortunately sometimes things go on longer than they should because it's so uncomfortable talking to faculty about these issues, especially in the absence of objective data, and especially when the faculty with whom we have to talk are faculty who were our mentors and who trained us. It's one of the hardest things, I think, one of the hardest things that we have to deal with as department chairs. But you all are correct. There's lots of literature. Various outcomes decline as years in practice increase. Disciplinary actions are substantially higher in people who've been out of school for 40 years versus 10, although those studies have to be looked at very closely to look at the number of cases and the complexity of cases that people are doing. The data suggests that older surgeons, for a while at least, remain competent in routine procedures, but lose expertise and efficacy in complex operations. So that makes things harder. And the other thing that makes things harder is conflicting literature. Everything we just said has been challenged. Tsugawa et al. Studied 900,000 Medicare patients and found that older surgeons had a lower mortality rate than younger surgeons, which is the opposite of what a lot of the other literature says, and suggesting that the outcomes are close, but that the older surgeons are worse. So with all that confusion and recognizing that we have a responsibility, what are we supposed to do tomorrow when we're back in the departments and back in the offices?
Bob, can I add one quick item to this? Because when I reached about 70, roughly, I had this question about myself, and I was talking to some older surgeons in the OR one day, and I asked them if they had thought about it yet, and one of them said, "Roger, what are you doing?" And I at the time I was doing mostly laryngology and MDLs and that sort of surgery. He said, what if the anesthesiologist has a bad day and something goes wrong in the OR? The first question they're going to ask is, how old is that surgeon? So I hung up the scalpel about 2 or 3 years after that because I thought a lot about that. That happens.
That's interesting insight and answer to an upcoming question. So what do we do if I don't see a volunteer? How about Earl?
Thanks, Bob. So what do we do for ourselves and our colleagues? Again, I get back to Dr. Weber is insight, knowing your limits, actually knowing, and I've been on the older side now. I've seen my limits and I know my limits. I've already limited what I do. And so that's what I do for myself. My colleagues, the ones whom I operate with, the pediatric colleagues, we operate together, and I can see in them if I see deficiencies. I can point it out to them. We can even go to the chair if necessary, but that's what we do. I think we have an obligation to patients, to society, and to patients, as well as ourselves. Again, we all remember first do no harm. So if I'm out there and I got some early Parkinson's and I'm trying to do ear surgery, complex ear surgery, well, that's a non-starter. And so, as a matter of fact, every day, not every day, but often I'll put my hands out and just make sure I don't have a tremor. I'm not putting somebody's child at risk because of my own arrogance and lack of insight into my own ability. So, okay.
Well, that's certainly one approach. It's one that I used. I wander in and out, or wandered in and out of my faculty's procedures and asked them to wander in and out of mine, and specifically to tell me if I was deteriorating. And I videotaped everything, and the residents and nurses and other people watch those videotapes. So, but that's still pretty subjective. Stacy, you mentioned testing. You want to be a little more specific?
Sure. I think one thing I'd like to mention just before that is, for all of us, one of the ways that we think about our careers is watching others. So we all have role models and certainly mentors that we look up to. And I think one of the things that really is very helpful in this regard is when we see someone who's very good at modeling what it looks like as you are progressing through your career and what it might look like to stop operating or change your practice. And watching people handle that gracefully and making it a normal part of our career process is one thing that I think would be helpful for all of us. Just because if it's something that we talk about and we share, like Dr. Harley was mentioning, just talking to colleagues, you count on your colleagues for accountability always. That's true at this point in my career. And certainly I think that will be the case in 20 years from now. And I think the more that we have these conversations, the easier it is then to make this just a normal part of what we all think about, as whether it's having requirements for stopping taking call, for instance, or a variety of other things. If you make objective parameters for this, it just makes it a lot easier. I don't think we're there yet, and I don't know the details about specific testing. I know from talking to some other institutions, there definitely are cognitive testing that you can do. You can have after a certain age, you can consider just instituting that it's something that's an age mandated type of assessment, sort of like driver's license or something like that. But I don't have any details specifically.
Okay, well, you will before the evening's over. Um, Anybody have thoughts on basic approaches to manual testing? We'll get to cognitive in a moment.
I think manual testing is non-existent. I mean, we all observe one another operating, but I know of no test that's informative and probably not ethical.
Well, observation obviously is what we do mostly. And as Jonas pointed out before, litigation, that starts to give us a hint that something manual or cognitive or both is wrong. Another potential over time, and the technology is there, we just haven't really used it yet, is simulation. I suspect that over time that will happen. And I would also suggest, uh, Stacy already mentioned something about testing starting at a given age. We're going to come back to that in cognitive testing, but I would argue that the given age is during residency. There's a wide variability in cognitive response and manual response. And if we test people for the first time when they're 60 and they don't seem to be up to what we wanted, we have no idea whether they're functioning at exactly the same level that they did when they were 40 and built a highly successful practice. So if we don't have baseline data, we do not have what we need to draw conclusions. We need control information in manual testing as well. So right now it's observation. It might be possible to have more objective assessment of manual function.
But Bob, can I just point out something before you go to that slide about simulation? Uh, as far as the aging surgeon, I'm not sure if we're there yet. I think, you mentioned my Navy career. Part of it, I was a flight surgeon in the Navy as well. So did a lot in aircrafts. And a lot of what they do in the aircraft industry, I'm not sure if you're going to talk about that. We've actually adopted and adapted it to surgery, otolaryngology. But they have very sophisticated simulation systems. I mean, and I'm not sure, when I'm simulating putting an ear tube in for my residents or doing a tonsillectomy, this is very different from what we actually need to, where we need to be in terms of testing somebody's ability at say my age.
I didn't mean to imply that the technology was developed to the point at which we're ready, but I think the technology exists. I think it's more developed in the airline industry than it is anywhere else.
Mhm.
But I would predict that over time it's going to improve. Certainly, the surgical simulation technology now is a lot better than it was 10 years ago. And I think it's just something that we should keep our eyes on as a possible future metric.
Mhm.
Do you agree with that?
Yes, absolutely.
Okay. And cognitive testing, we'll talk about what to do in a moment, but if anybody wants to disagree with me, I would suggest that cognitive testing begins in residency as well for the same reason. There are people with auditory processing disorders. There are people even with visual processing disorders in some areas of surgery
Mhm.
and with other cognitive issues for which they have compensated well throughout their lives. And if we recognize them for the first time when they're 60, we're going to say, oh, he's losing it or she's losing it. So I think that we need early testing, and I will show you when we had a panel on this more than a decade ago, that was a novel approach. You will see with a quick ACS summary that that's become more popular. Now, the question remains as what to do. We need to get baseline data. There's lots of neurocognitive testing. Uh, Actually, in 2016, wrote a paper that summarized the various domains of neurocognitive testing for potential use. But the short story is we need a very specialized neuropsychologist to work with because neuropsychological test batteries take 6 to 8 hours, and that's not practical. But just like many of our questionnaires that started out at 30 questions and ended up at 10 questions because there was no difference in the predictive outcome, there are ways in which people are currently working on reducing cognitive testing so that it can be done in a reasonable period of time in a screening fashion. And I would suggest that we as leaders and as people who are responsible for physician credentialing need to stay current with that literature and with that group of colleagues until we come up with something that we can agree upon and standardize. But whatever it is, manual or cognitive, we need some baseline. We just can't start testing people because they're 60 and expect to know whether they've changed. What other issues should we consider when we're talking about retiring? What is the impact of somebody like you retiring? Jonas, you're first.
Uh, Well, I can only speak to my own situation. Um, I indicated earlier that I was involved in trying to improve the safety profile of surgeons across our organization. And as I became increasingly aware of how important this was, I made the decision to retire from the operating room, when I turned 70. So that was about 10 years ago. And I just announced to the department that I'd made that decision. But the real reason I did is I didn't want anybody to ever talk to me about it. I wanted them to weep that I was stopping rather than cheer that I was finally stopping. You understand the difference?
Mm.
And then actually the same thing happened 3 years ago when I asked the dean to replace me as chairman, because I think the department benefits from a fresh leader and change. So I asked the dean to replace me. And he said, I was thinking about replacing a couple chairmen, but you weren't one of them. And it's exactly the same thing. I didn't want the dean to ever ask me to leave. I'm too proud for that. So I left. And I'm listed now as emeritus because I did retire from the University of Pittsburgh, but I continue to run a couple of clinics a week. So I'm still involved, but I'm not involved with the high-end surgery, and I don't work 5 days a week. I might attend grand rounds and tumor board, but I'm only really involved with patients for a day or two a week. So it's kind of a soft landing for me. I miss it. Please understand that I miss it. So the joke, that is the line I used when people ask me, is I say, yes, I would prefer to be 35. But that just isn't the way it all works. Yes, it would be fun to be 35 or 45 and stay that way forever, but that's not the way it works. And so I should be happy that I've gotten this old. I should be happy that I'm still involved and interested in medicine. But I stepped away before anybody felt like I ought to.
Admirable. I did the same thing. So did Roger. So did my wife, who stepped down as surgery chair in the Penn system for the same reason. She had to encourage a couple of her former mentors to leave the department and decided she never wanted to be in that position. Roger, would you pick this up and talk about the effects of retirement, not on the person who retired, but on others and on the system?
Yes, well, thanks. I was thinking as Jonas was talking that I just about followed the same track he did in maybe a year or two or three later, but I'm older than Jonas. But I remember one of our doctors at UCI was hit his 90th, and I talked to him, and he was still seeing patients once or twice a week, and I talked to him, and he said, well, he says, it's part of aging, and he says, I've learned that, and you should do this as well. He was advising me. He says, don't ever stop things you're doing. And I thought, well, but the medical practice is different. And I mentioned that to him, and he agreed. But he knew that I played the trumpet and played the piano and played golf, and those things. I would say one should keep doing, and you should prepare for retirement by thinking about those things, because you don't want to be doing boring things that you don't like to do in retirement. You want to continue with the hobbies you've always enjoyed. And I agree with Jonas. I miss the OR. I miss seeing patients, although I still see about a half day a week. Jonas, I'm ahead of you a little bit in that schedule. And so I still enjoy that half day, but I miss all the rest that isn't there. But the fact is that one thing we need to do, and maybe this will help tonight, Bob, is that those who are 35 and 45 in that age group that Jonas mentioned, they may not realize they're in the prime of life. I mean, they're doing the thing. Sometimes those days are long and they're arduous and they're difficult. But that 7 a.m. meeting followed by 7:30 surgery and then a 5 o'clock meeting and maybe an evening meeting, and you think, oh my goodness sakes, that's the prime of life. All those things are giving you endorphins. They're giving you things that Hans Selye, the famous biologist from Canada, talked about in his wonderful book, which I recommended. Bob, you may remember a few years ago, Stress Without Distress. I mean, those endorphins and adrenaline and other hormones are good for you, and that's what keeps you going. And you're getting those in spades during your 30s and 40s and 50s. I miss it a lot. I'm not sure if I answered your question, Bob.
You provided invaluable insights.
I just wanted to interject that Dr. Pinzak added something to the chat that I thought was a good comment, and just for people to address. He said, please address the identity issue for physicians, as so many of our colleagues see self-worth and value with the title of.
We can do that now. There's a question about it later in the lecture, but since you started, Stacy, go right ahead. Stacy, you're muted and it looks like you're frozen. So,
Yeah.
there, you're moving again.
Sorry, I
You
don't,
want to
my,
ask, do you want to address Miles' question?
no, please do.
So
Okay,
I'd like to
Earl?
address this
Yeah.
question.
Oh, Judge,
I mean-
well, I did have a comment. I wanted to address the same question as Stacy, actually make a comment. And it boils down to whether or not we view what we do as a job or as a calling. You know, as a calling, I think we have trouble separating ourselves. We have trouble stepping back because we feel an obligation to society, even when we ourselves are on the decline. We feel we can't step away. What's going to happen? Who's going to see this patient? Who's going to take the call from the pediatrician? So as a calling, but as a job, which many, maybe the younger physicians, so I'd say under 50, is more of a job where it is more of a work-life balance, whereas those of us who are on the older side of 50, it's, at least for me, it's a calling. And I think that's what Miles is talking to. So my identity is tied into being an otolaryngologist, being a medical doctor, and this is not just what I do, it's who I am. So, and it's tough. It's tough to separate, and I admit that.
Miles, it's a good question, and we will come back to it again in slides a little later in the panel. But it ties in very well with the issues that I wanted to address with that question. When we talk about retirement, most of us think about ourselves and the effect on ourselves, but there's a lot more to it. Stacy, you're sort of beyond it, but 5 or 10 years ago, when you were working closely with a mentor, if that mentor all of a sudden leaves, that has an effect on you. Our retirement affects our students, our residents, our younger faculty. It affects the chair, who may have to reconceive and restructure a division in the department. It affects the reputation of a department or of a practice. Same thing in private practice, and potentially referrals. So it's not just us, but it has to do with healthcare delivery and with healthcare finances and with continuity of care. In many cases, people come not because of an institution or a practice name, but because of an individual doctor. And getting the same kind of care is not always possible. Those factors make many of us hesitate even more and maybe forget about the fact that we are not truly irreplaceable. It's just that they're factors that we have to help prepare for. Um, More doctors are working longer. We have physician shortages. And when those of us who grew up in a work ethic era retire, it's going to take more than one doctor to replace us. There's plenty of good literature on that. We have experience, knowledge, maybe even wisdom that we lose if we not only retire but also disappear from the healthcare environment, again, academic or private practice. Interesting to note that when you survey physicians, they expect to retire at 60. They actually retire at 69.
Hmm.
Otolaryngologists, the number is 67. Jonas was 70. Roger was a little older. I was 75 when I stopped surgery in clinical practice, but maintained all the chair activities. We are outside the normal population. So what all can we do to practice for as long as we want to practice safely? Jonas, you haven't said anything for a little while.
So, a lot of this is just preparing oneself for what amounts to normal trajectory of your life. I mean, people were saying to me 30 years ago, you should always have something outside of medicine that you're interested in. And I think that in our generation, it was sometimes easy to forget that advice, but I think it is good advice. And as one comes to a time when you need to slow down surgically and in the clinic, it really helps to have other things that interest you that you want to participate in. So I think everybody ought to worry about that just a little because I think everybody needs to understand that eventually each of us, will come to a time when you really ought to kind of hang up your boots.
And hanging up your boots doesn't necessarily mean leaving the practice of medicine.
It doesn't. I think you can still be engaged in a variety of ways. I think there are more ways than ever today because our society has welcomes a change and new initiatives. I have to tell you that I've spent the last decade of my life putting together a survivorship clinic in an effort to care for patients who are living with the late and long-term side effects of cancer therapy.
And are you still involved with that?
Absolutely. I do it every week.
And that's exactly the point. So you've changed your activity, you've changed complexity, you've changed your patient demographic, and you've created an innovation that allows you to continue to not only contribute, but also interact with colleagues and students. So retirement doesn't mean stop, it means evolve.
Right. So the way I described it to friends who ask is I said I re-engineered my career.
Exactly. And that benefits the so-called retiree, but it also benefits the whole community. So we've already discussed probably adequately, unless you want to add something, testing beginning early, continuous competency testing. What we haven't talked about and what's scarce in the literature is correlation between any of those test results and clinical outcomes. Who knows if you test cognitively impaired, whether that means that your patients are going to do any worse. And before we start applying the tests, which are applied at some institutions, both manual and cognitive, wouldn't it be nice to know if those tests have any implications at all for the practice of medicine? So far as I know, that's unknown. I suggested, and I have to admit that with the other things I've written, I haven't gotten around to this, but in looking for things that are easy to test, many of us test frailty routinely when we're about to do a major operation on an older person. I would be very interested to see a study in which we do standard, simple, quick frailty tests on surgeons and compare those with patient outcomes. That would be really easy. You could do 2 or 3 minutes worth of testing. But doesn't it seem possible that people who have decreased grip strength and who can't stand up, walk 3 meters, and get back and sit down again in 10 seconds may not be 100% in the operating room? Something potentially easy, straightforward. I have no clue because all of the studies have been about frailty in patients and patient outcomes, and they show a correlation. How about looking at frailty in surgeons? Something easy. So while we're waiting, there are institutional programs. They have strengths and weaknesses. Stanford, Hopkins, many others. Penn. I still have hospital privileges and malpractice insurance. And once I hit 65, I had to go take cognitive testing on a computer and rapidly tap the keyboard. And I almost flunked because I'm so bad with computers. So there are lots of strengths and weaknesses. And again, the relationship between those test results and care efficacy and physician safety is unstudied. Unstudied. We should all be aware. I'll run through this quickly, but I just want everybody on the call to be aware that there is an updated American College of Surgeons statement on the aging surgeon. Came out in 2015 and was updated last year, and updated pretty well. It pays attention to wellness and lifestyle, objective assessment of fitness, and I would suggest maybe frailty goes in there. Lifelong assessment, that is new. It's just what we were talking about. Stacy should have been taking these tests for years already and not take them for the first time when she's antique, such as the rest of us. It it acknowledges the fact that colleagues and staff need to have input on quality and outcomes of clinical care. That's the observation that we discussed. That's in the current ACS statement. It acknowledges that neurocognitive testing requires further validation. It also requires efficiency, as we discussed, and not just validation within itself, but correlation with test results and clinical outcomes. At present, the ACS suggests, and is probably right, that if a competency issue is questioned, then additional evaluation, peer review 360, observation in the operating room is appropriate, and in some cases, referral. Now, there are organizations that do testing. They do comprehensive testing for a couple of days and put out reports on function and to some extent are able to tie it with aging, but are able to tie it with competency. We need a lot more research, and we need long-term career transition planning. Remember, these are current, last year's ACS statements, long-term career transition planning, which I'm not aware of actually being well in place anywhere. Stacy, you're a residency program director. Do you talk about transition planning and retirement with your residents? Is that part of the training program?
I can't say that it's something we typically talk about.
Right. You and everybody else. But arguably, we should be, because that's the time when people should start recognizing that life is relatively long and involves predictable physiological and psychological changes that we should prepare for early on. Other activities are one way, but there are lots of ways. The ACS statement also recognizes that senior surgeons are vital. And just as both Roger and Jonas have retired but stayed active in patient care and in education of colleagues, losing the wisdom of senior surgeons is a major mistake and is still happening in institutions all over the country. decisions on privileges require consideration of all evidence and require due process and confidentiality, and we all know that's not always the way it works. It's a little better, I think, in academic institutions than it is sometimes in small community hospital settings. But I don't have data to prove that. And it's an issue that requires everybody to be involved. You can ignore this while you're answering the question, but Earl,
Wow.
what do you think are the important factors that help decide when you can and if you want to and if you will retire?
First of all, I look in the first column, number 3, satisfaction. Once is no longer fun. Once you dread getting up in the morning, knowing you won't get home until 6 or 7 o'clock at night, then you should think about it. That would be number 1. It has to be something that you enjoy, something that gives you pleasure, something that you see that there's a value to your patients, to society. If it's not that, then you need to step aside. That's I would put that.
We're going to go straight down. Stacy, if you were thinking about retiring, which of these factors would matter to you?
I'm going to have to agree with Dr. Harley. I think just in general right now, I think one of the things that I really think about is the fact that being in the operating room, caring for patients ultimately should be fun. That should be sort of what you enjoy and what drives your enjoyment. And so certainly if that was changing, that would be a big signal to me that I need to think about doing something differently for sure.
Roger?
Well, I agree with Earl and Stacy, what they said. I've been thinking a little bit about your slides on the ACS, and now correct me if I'm wrong, but to my knowledge, the ACS has not implemented all of those things to the point where they would take away somebody's ACS credential. They may be working on that, but beyond that. What I don't know is whether any state medical board has undertaken such a task, but I think that's going to happen eventually. And it takes me back to long discussions with American Board of Otolaryngology about maintenance of certification. So we know that the American Board of Internal Medicine has, I believe, they've abandoned that after many years of working hard at it and doing a pretty good job at it. I believe they've abandoned that, and so what you're talking about and what we're talking about here is maintenance of ability, really, and maintenance of capabilities, and so maybe there should be some testing by one of these bodies to take us all to the task that Jonas and I have avoided so far by stepping aside in a timely manner. But I think that at some point there will have to be some institutional rulings or measurements that we'll have to abide by.
Well, there is no ACS action, and you will notice that that's a statement, not even a guideline. So it's more insightful than the old statement, but it's soft. You raise an issue that I think is important. If we don't do something ourselves, somebody else will. There are mandatory retirement ages for the FAA, FBI, air traffic controllers, lighthouse operators, and national park rangers who have to retire at 57. If we don't do something to maintain safety within our profession, somebody else probably will. Jonas, you want to weigh in on anything?
Well, this has become kind of complex and convoluted. Yeah, I think you're right. I think that what we see, or at least what I think we've been observing during the course of my career, is increasing oversight from third parties, the government, etc. I think everybody on the panel and probably everybody in the audience understands that in the EU, there is mandatory retirement. It's roughly 65 years old. It has always seemed cruel to me because most of my colleagues are still very, very functional and effective when they're 65. So we've been lucky to practice in this country, but I think that we will see changes.
I would also point out flexibility of work hours. There still are places that say either you work full time or you don't work. That forces people into retirement earlier than they want to be. Work dissatisfaction, time inflexibility, and activity inflexibility. There's still places that insist you take, if you're still practicing, you take call. At the age of 70, you may have a lot to contribute, but you may not want to get up at 3 o'clock in the morning anymore to handle a nosebleed. Burnout, there are lots of other issues. I don't want to run out of time and not have any time for questions, but there are some factors to consider to make retirement successful besides the ones we've discussed. Uh, Transition planning, we've talked about, helping guide other people to take over our patients to work with their departments. Finances are an issue too. It's unfortunate, but for some people, there are doctors who continue working because they can't afford to retire. There are a lot of reasons that play into that, from poor financial planning to multiple divorce, but nevertheless, it's a factor and not a very good factor for patient safety. So almost all of you have been in leadership positions in major institutions. How about opportunities to retain physicians? Any of these jump out at you? You want to make any comments? As Jonas pointed out, mandatory retirement ages and ageist stereotypes are sort of one and the same. Institutions need to avoid those and to be flexible and make whatever changes people need in order to maintain active, older, wise people. There are a lot of organizational challenges. Figuring out how to work with potentially retiring physicians to maintain patient continuity and patient input into the practice or institution is critical. And if institutional succession planning doesn't start early, by the time people say, I'm going to retire next year, it's too late to really do it right. So we're back to Miles' question. I think the answer that we got, I think it was Earl's answer, was pretty important. It depends a whole lot on whether being a surgeon is what you do or what you are. And a great many of the people who go into otolaryngology in particular are well-educated, culturally diverse people. We have a fair number of musicians, a lot of artists, a lot of athletes. We don't maybe encourage continuation of those activities during 80-hour work week residencies, or include anything in our residencies about the importance of such activities in lifetime physician wellness that helps promote long careers. Maybe we should be. Maybe that should be part of our early education, because all of us who get near retirement look at other activities, as Roger and Jonas have both mentioned. And Gene Myers was on one of these panels. He retired and ended up being president of an opera company, if I remember that correctly. When you have other things to do and other things to contribute that you've developed throughout your career, transitioning isn't stopping, it's not quitting, it's rebalancing. Anybody want to comment on that? I'll just make one more comment that rebalancing rather than stopping is important if you don't want to be subject of a late divorce. People who retire and stop, who all of a sudden spend all day with a spouse, sometimes find that's not anything that we can just assume is going to be received with great enthusiasm. Amplification before we move on to the last slide. Final thoughts and comments, and then questions if we have time. We'll go in the order in which we started. Stacy?
I guess I actually have a question for the panel and sort of a lot to hear some insight from everyone. Something that you alluded to a little bit. So for someone that is sort of in the middle of their career, what should they actually be thinking about? What should they be considering when they're thinking about an exit strategy? That's actually from Dr. Simon's question, but I think it's a good one for those of us that are sort of thinking about retirement in the next 15 to 20 years. What are some things that we could do to actually make that a positive experience?
Quick comments from everybody, please. Earl, you're first.
Yeah, I would think about, Stacy, good question. I would think about where you want to be in 5 years. Also, it depends on your family, where your children are, where they are in college and things like that, and where you want to be personally. If you want to be a chair in 10 years or 5 years, think about that. And then how do your a glide path, I'll use another aviation term. What's your glide path to retirement from where you want to be, from where you are now, where you want to be in 10 years, and then 15 to 20 years from there? Just kind of give it some thought. Yeah.
Roger?
I would say, personally, that it's important to continue all your hobbies while you're doing that, and the career will take care of itself because you have to do those things and you want to do those things. You can't stop yourself, but the hobbies you can forget about, and you shouldn't, because you'll need them in retirement.
Jonas?
So I think it's so complicated, Bob. I agree entirely about the hobbies. I agree about planning with your family. I think that you need to make some financial planning and think about that. It's a very complex topic. It's nice to have a partner who you can talk to about it, not just your wife, but perhaps some of the people you work with.
Stacy, I would add one suggestion, and that is to take a week off, not do any medical work. I have to admit that I never did this. You know, I take a week off and I write a book, but take a week off, don't do anything medical, stay home and see if you're bored. Because if you're bored, then there should be more in your life that you get to do and have a lot of fun with during your week away from medicine. And if you're doing art or music or playing tennis or golf or whatever it is, and you're having a great time and the days go by quickly, then you should recognize what made you do that and keep it and develop it. And if there's nothing there, it should be a red flag. And you should fix it now, not when you're doddering around.
Well, I was just in New Zealand for the last 2 weeks hiking with my husband and had a fabulous time. So
Perfect.
I think I'm okay in that regard.
Perfect. Yeah. Earl, any last questions
Yeah.
or comments?
Yeah, Bob, I was thinking about we're all in academics, and we have an opportunity early on with our students. And I'm recalling particularly one student who was the most productive student I ever had, at churning and burning, getting the papers out, presenting. And I had to sit him down and said, you need to take time, we do something else. In other words, don't
led medicine just so you do that you don't take time to smell the roses, to use a trite expression. And so, right, go hiking, like Stacy said, or, do some other things early on as a medical student, because we know burnout starts in medical school anyway. So early on in your career, start, having these outside hobbies, outside interests, and then I think you'll be much better off for
Roger?
in the end.
I think I've spoken my piece about the hobbies already, and that's enough. And Earl mentioned that as well. So I don't have anything further at the moment.
Jonas?
I have nothing further.
Jeff, this concludes our adventure for today, and it looks to me as if we're 1 minute late, but I'm sure that we would all be happy to take questions from the audience if you and Beth and Colleen give us permission to do so, or we will sign off if you need to stick to the 1 hour. We all want to thank Jeff Simon for inspiring this webinar and inviting us to participate, and Beth Phobel in particular, but all of the people in the triological office who are so invaluable in getting everything done so smoothly. Thanks, everybody. Jeff, what's the word? Are we done, or should we take questions?
Think
We're
that,
done, Bob.
we're done, and all the questions have been answered. I want to thank all of the panelists very much for participating and all the insightful comments. We all learned a lot this evening, and thank you, particularly Bob, for moderating the session, helping us put it together. We're really grateful, and I look forward to having the group join us again for the next Beyond the Otoscope webinar, which will come up probably in the spring.
Thank you to the Trio people, and thank you especially to the wonderful panelists. A pleasure working with everybody.
And thank you, Bob.
Thanks, Roger. My privilege. Good night, everybody.
Night.